Gus, Monterey County Superintendent, and I am thrilled to welcome you here today to this afternoon's webinar. Before we start off, I just want to say a huge thank you to all of the educators across Monterey County who have been working so hard each and every day in support of our students and our families. We know that working in the distance learning mode and working in the limited in-person capacity that we've been able to operate in has been very, very challenging. And you have really been pushed to the limit like never before. So please know how much we appreciate your dedication, your passion, and how important your role is to the students and families of Monterey County. We also know that you are all hearing that educators are going to be eligible starting March 3rd to receive vaccinations. So it's super, super important for us to all have a really good understanding of what vaccines do for us, what they do not do for us, and just get all of our many questions that we have about the vaccines answered so that we can confidently make our decision about whether or not to take the vaccine when it is offered to us. So we are so fortunate today to have Dr. Alan Radner with us. And I want to do a quick introduction of Dr. Radner. But before I do that, I just want to say a huge thank you to Dr. Radner. From day one of this pandemic, I reached out to him and I said, help, we're educators. We are not health experts. We are not doctors. And we really need your support and your assistance as we try to both plan how do we work safely in the workplace and how do we plan for the reopening of schools when that time comes. And Dr. Radner gave of his time, his energy, and he attended safety plan meetings. He's answered questions throughout this entire year now, and we know that that has taken a great deal of his time. So Dr. Radner, please know we are so appreciative and we thank you so much for all of the support to the education sector. And with that, let me give you the proper introduction. Dr. Radner earned his medical degree from Rush Medical College in Chicago. He completed an internal medicine internship and residency at University of California, San Diego, and continued on to complete his infectious disease fellowship at Harbor UCLA Medical Center. He is board certified in internal medicine and infectious diseases by the American Board of Internal Medicine. Dr. Radner joined the medical staff of Salinas Valley Memorial Healthcare System in 1994. He's held various leadership positions at Salinas Valley Memorial Hospital, Natividad Medical Center, and Community Hospital of the Monterey Peninsula. Dr. Radner joined the executive team at Salinas Valley Memorial Healthcare System in August of 2013 as the Chief Medical Officer. In October of 2019, he was named Chief Executive Officer of Salinas Valley Medical Clinic. Dr. Radner also serves as clinical professor, Department of Family and Community Medicine for the University of California, San Francisco School of Medicine. Oh, I'm going so fast here. Medical doctor of the Natividad Immunodeficiency and Infectious Disease Clinic, and as Monterey County Tuberculosis Controller. Dr. Radner, that you have so many certifications here and you've been so actively involved. I couldn't even hardly read all of that fast enough. With that, please take it from here.
Thank you. That introduction was longer than my presentation, so thank you. And thanks for asking me to speak. So I'm going to go ahead and kind of run through a PowerPoint presentation, which in various forms I've been giving throughout the county to doctors, to residents, to staff. So this is a modification of a kind of classic Grand Rounds presentation. So let me see if we can pull this up appropriately. Share screen, and then what do I hit? This one. And will it move? Okay, got it. Thank you. Okay. So why don't we go ahead and start? And I'm going to run through these slides. I have about a dozen slides, and then the last few have a bunch of FAQs on it, but I guess we're going to open this up to questions through the chat box as well. So as I've mentioned at the beginning, it's a tiny bit technical, but I think, there's terms that probably everybody's heard. They're not terribly technical, but it'll get a little more kind of practical as we go on, but I'm just going to kind of run through this as I've been doing this presentation to physicians and to staff. So I think everybody has heard this and seen this, that this virus, this SARS-CoV-2 virus, is a virus that we generally speaking inhale, bring into our respiratory tract in one form or another. And what happens is it binds to some of the cells on our respiratory cells, on our lung lining cells. And there's a specific receptor there called an ACE2 receptor, which is, again, part of us, one of our cells. And the virus binds and is taken up and then starts replicating and proliferating and causing the things we find with infections. One of the kind of key terms that we're going to talk a lot about is this concept of immunity. And the idea is that we develop antibodies, which are these proteins that fight off infections. And in this case, neutralizing antibodies are specific antibodies that bind to that spike protein, preventing it from binding to preventing the virus from binding to the ACE2 receptor and being taken up. So it's really kind of shutting down the cycle by having these antibodies. And in the picture in the bottom corner, I'm not sure if the pointer is working, but it's a little hard to see, but we actually develop a whole bunch of antibodies, and we develop them to various parts or epitopes on these spike proteins. So we get what's called a polyclonal antibody response. I'm kind of getting, oops, I'm sorry. I'm trying to adjust my screen a little bit. That's okay. I think everybody's heard a lot about this term of variants, and this becomes germane, and there were a lot of questions about variants that were forwarded to me. But basically what happens when a virus is replicating over and over again is there are these mutations, intermittent mutations, or, conceptually you could think of them as a mistake in the viral replication. Many times these mistakes just lead for the virus to die, but sometimes a mistake kind of inadvertently will provide some selective advantage to the virus. So what may happen is that these variant strains may have a change so that the spike protein, for instance, may have a conformational change and actually bind to the ACE2 receptor better and lead to potentially making it more infectious. You may get more viral replication, you may get more serious disease. And one of the real concerns is those antibodies that we talk about may not be able to bind to the new spike protein, which may have been different from either the antibodies that you generated from your previous infections or an infection, or the antibodies you generate from a vaccine. And I've listed these down here. There's a lot of debate about, again, issues related to the infectivity, severity, and whether or not our antibodies, either vaccine-induced antibodies or previous infection-induced antibodies, will work as well for these variants. And we know, for instance, that this so-called UK variant, the B.1.1.7, is thought in the next month or two to be the predominant strain in the United States. And it clearly is more infectious, and it may replicate better, and it may also cause more serious disease. There's a strain we're looking at pretty closely in Northern California, which is actually about 75% of the cases in Monterey County now, the so-called B.1429. We think it's more infectious. There's no clear understanding right now whether it's more virulent or lethal, and whether or not the vaccines will be less effective. Our belief right now is that both the UK variant and the California variant probably aren't going to have enough of a change in the spike protein that immunity that was induced by a prior infection or immunity that you generate from a vaccine is going to be prohibited in any way. The vaccine should still work fine. So this is a kind of cartoon representation talking about vaccines now. So, again, it's immunity, it's vaccine. And the whole concept that we've already said is that you've got this kind of cartoonish drawing of a SARS-CoV-2 virus with these spike proteins. And when you're infected, you develop antibodies. And again, the antibodies ideally will block the uptake of the virus into a normal cell. And in the bottom left here, you can see there's, again, a cartoon drawing of a natural infection. You get infected and you have the spike protein and you go through the cycle of your infection, but virtually everybody will develop antibodies within about 7 days, at least some antibody response. Vaccines are all the vaccines that we're going to talk about, all the vaccines that people are looking at are all directed against that spike protein. And conceptually, the way vaccines were made was that you would take the infecting virus or bacteria and you either kill it or weaken it, but these antigens, parts of the virus or parts of the bacteria that are exposed, you could still develop antibodies. So ideally, you'd have a partially killed or a killed virus, and it couldn't replicate, it couldn't cause infection, but there was enough of it there that you would develop antibodies. And that's what most of historic vaccines were, killed or live attenuated viruses. Another type of vaccine is what's called a protein subunit vaccine. And there's actually, we'll talk about this, but there's one that will probably be available in the next few months where they actually in cell culture figured out a way to grow some cell lines that will produce the protein subunits, and then you pull out these protein subunits, the spike proteins, and you inject the protein subunits into an individual, and they'll develop antibodies. So there's no fear of getting an infection. You're just seeing those spike proteins, but you're developing, again, protective immunity with antibodies. And people may be aware there are some protein subunit vaccines that are available. The human papillomavirus vaccine is a protein subunit vaccine. What's really novel and what we're talking about, all the vaccines that are coming to the front now, have really never been used in humans, and they're an entirely different concept. They're RNA or DNA vaccines. And the idea is that they've taken out from the virus the genetic material, in one case, the mRNA vaccines, they've taken out the mRNA and they've actually put it in what's called a lipid nanoparticle. They inject it in your muscle, that messenger RNA, which actually doesn't live very long outside of the cell, gets into the cell, and then the cell machinery actually has the ability to translate that, or it makes the protein subunit. So your body is acting as kind of like a manufacturer of these spike proteins. And that's what the messenger RNA vaccines are. The adenovirus vaccines, like the J&J vaccine we'll talk about, are slightly different. They take an adenovirus that they've altered so that it can't replicate and can't cause infection, number one, further infection. Number two is these are relatively benign viruses, and they insert in it the RNA, it's actually the DNA, but it's transcribed and then translated into the RNA that makes the protein subunit. So again, your body is acting as a kind of manufacturing plant for the protein subunits for these spike proteins, and that's how we get immunity. I want to make it real clear that nothing's alive in the messenger RNA vaccines. In the adenovirus vaccines, they are engineered so essentially they can live long enough to get in a cell, but they can't replicate, they can't cause any other infection, and they're certainly completely unable to make a COVID-19 infection or a SARS-CoV-2 infection, because they don't have anything but a very small amount of the genetic material that makes that spike protein. So these are the vaccines that you're hearing about in the news, and this is what we have. So right now we have two messenger RNA vaccines, the Pfizer and Moderna vaccine. The J&J vaccine is being discussed at the FDA as we speak, and maybe as early as tomorrow that it's going to get an FDA EUA, and we'll talk about just what that is. And then there's a number of other vaccines that are either out there in other parts of the world or in advanced studies. The Oxford and AstraZeneca is an adenovirus. It's actually a chimp adenovirus, the so-called Sputnik. I thought it was Sputnik 5, but it's actually Sputnik V for vaccine, Russian vaccine that's been approved. And actually the literature they've published, principally in a journal called The Lancet recently, looks outstanding. And there's a, as I mentioned, a viral protein subunit vaccine by a company called Novavax, which will probably be the next vaccine that's available. So these are all the vaccines that we're hearing about. But again, so far it's only been Pfizer and Moderna. And we'll talk about some of the differences as we go on. So what I thought I'd do is talk about the Pfizer study, and not that it's, the end all and be all. I'm not going to go through all the studies, but I think it's pretty illustrative understanding the Pfizer study, which was the first one that was published, the first vaccine that was made available, but understanding kind of the issues and the terminology and what we know about that is applicable to all the other vaccines, and it's all kind of, referable. So this was the article published in the New England Journal of Medicine in December, and they talked about the first significant trial looking at this messenger RNA vaccine. So again, most people know this. What they did was they had roughly 43,000 participants, 21,000 people received the vaccine, whatever the other group was, received a placebo. There were 2 doses, 3 weeks apart. You got a vaccine, you got another one 21 days later. They only enrolled people over 16 years of age. You had to generally be healthy and have stable medical conditions. It was a worldwide study. If they knew you had COVID-19, you weren't enrolled. They tried not to enroll people that are immunosuppressed, but they acknowledged they enrolled a number of immunosuppressed people, particularly HIV patients who are on stable medications, and they did not knowingly enroll pregnant women. And let's talk about what they found. So again, it's applicable to what we're talking about. So the first thing, which is critically important, is to talk about what's called a primary endpoint is. And what they did is they defined a failure, so to speak, is 7 days after your second dose, if you developed a symptomatic infection and you had a positive test. So they weren't checking people every day or once a week. And it's possible, as we know, people have asymptomatic infections. But what they were looking for was, and they also knew that it would take some time for your body to have a response and get immunity. So if the day after your first vaccine you got COVID, that probably wasn't a vaccine failure. They knew that your body didn't have the opportunity to develop immunity. So the way they structured this was day 1, day 21, 7 days later, did you get symptoms? They tested you, and if you were positive, you were considered somebody who developed symptomatic infection or essentially a failure. And what they found, and you can see the chart in the bottom right, it may be a little too small to read, but these blue circles, the upper line is a graph of cumulative infections in people who received placebo. And the red line were the cumulative infections in people who were vaccinated. And you can see that at about day 7, actually, if you blow it up, it's about day 10, the number of infections almost disappears in the people who are vaccinated. And it continues to rise in the people who were not vaccinated. So what they found were they followed people for 2 months, a median of 2 months after the after that endpoint, the 28 days or 7 days after the second vaccine. And they found there were 162 cases in people who received placebo, and they would have expected, if the vaccine didn't work, to have a comparable number in the vaccine arm. And what they found were 9 cases. And what's critically important is the cases were all mild. No one was hospitalized. I take that back. There may have been 1 hospitalization. No one died. And that there's some debate about whether there was a hospitalization within that time period. But essentially, we know no one died. And we know that with respect to the number of infections, there was a 94% reduction, the difference between the 162 expected cases and the 9 that they found. And, there's a lot of discussion about this. I recently heard a pretty detailed analysis by Dr. Paul Offit, who's one of the premier vaccinologists in the country. He's at the University of Pennsylvania, and he's actually on the FDA advisory panel that approved these vaccines and is on the panel for the J&J vaccine. And he actually states there's been a lot of criticism that we've done this too quickly. And, the vaccine development has been astoundingly quick for a lot of complicated reasons. But he said the trials were essentially like almost all the other vaccine trials in the sense that they had the same primary endpoints. They looked at complication rates over the same period of time. Efficacy was the same. Really, the only difference between what we're seeing with the COVID-19 vaccines and historic vaccines were that we didn't follow this to know the long-term or sustained efficacy. So with previous vaccines like rotavirus, they would follow people for a year and see if they maintain their immunologic response and their vaccine efficacy. And given the kind of concern and the number of people that were dying on a daily basis, they haven't decided to just watch these people to see if there was sustained efficacy. But with respect to short-term efficacy, at least, the standards that are looked at in the trials and the safety, he said it's exactly what they do in almost all the other vaccine trials. So here's the discussion of safety. So you've all probably heard stories if you haven't been vaccinated or friends have been vaccinated. This is what they found in the Pfizer trial, and almost all the trials are coming up with pretty similar numbers. A large percentage of people will get some symptoms after the first dose. In their initial trial, there were fewer symptoms after the second dose. We're mainly seeing more more serious. When I say serious, these things like pain, fatigue, some arm swelling, we're seeing a little more of that after the second dose. But those are the symptoms that we're seeing. And the majority of patients have something. They're sore the next day. They may have something like headache, fever, fatigue. There's anecdotes about people who are sicker. I've had a few people that stayed home for a day or two. Almost everybody's better within 48 hours. And in the Pfizer trial, at least, when they compared real serious, what they're calling serious adverse events, like their arm became really swollen, or they had some arrhythmias, or they had they didn't have anaphylaxis in this trial. I'm going to talk a little bit more about that. Actually, people had those symptoms in the placebo group, and there were really any significant differences between the vaccine and placebo groups. Again, there's a difference between 40,000 people and millions of people, but these numbers are holding up pretty clearly. I'm going to talk more about pregnancy, but in the Pfizer trial, for what it's worth, 23 women became pregnant during the trial, or they were pregnant, didn't know it at the beginning, and then they found they were pregnant. And for what it's worth, in their trial, all the pregnancies did great. And I'll talk about that a little more as we go on. They basically said everybody can get vaccinated unless you are known to have a severe allergic reaction to an ingredient in the vaccine. And it's mainly something called polyethylene glycol, which is something most of us haven't been exposed to. It's actually used medically mainly as a laxative. So we asked people, have you ever had a colonoscopy? And the colonoscopy prep has polyethylene glycol in it. And having diarrhea or an upset stomach doesn't count. But if you really had a serious allergic reaction, that would count. I've actually never seen that, but that's what we're kind of looking for. And then if somebody had a really, really bad reaction to the first dose, then we would also consider that a contraindication and want to give them the second dose. The kind of life-threatening reaction, allergic reaction people talk about is something called anaphylaxis, where you become very swollen, you can get airway compromised, your blood pressure can go down. The good news is it's completely curable. We give people some epinephrine and they do fine. There's some uncertainty as to how frequently that happens with this vaccine. They were reporting about 2 per million doses. There's some reports up to 11 cases per million doses. It's coming in probably somewhere, closer to 3 to 4 every day as there's bigger numbers being accumulated, more and more people are being vaccinated. There's a new report kind of readjusting that number. And to put it into context, about 1.3 in a million people who receive the influenza vaccine get anaphylaxis. But if you look at penicillin, it's about 100 in a million. So, again, it's pretty rare. I can tell you our system is vaccinated about 7,000 people. And we've had a number of people who feel anxious and their heart rate goes up. We haven't had to give epinephrine. We're completely unconvinced that we've had anybody have anaphylaxis. And we've had lots of people who are sore and achy and headaches and didn't sleep that night. So again, it's not without symptoms. So I've just included this slide. This was a presentation I gave to the staff at Memorial Hospital and Natividad after we first started receiving the vaccine for healthcare workers. And you can see it's a little dated, unfortunately, in the sense that at the time it was kind of interesting to me because we'd had 20,000 people in Monterey County who had been diagnosed with COVID at that time. It's actually, unfortunately, we were in the middle of this horrible surge. It's now 40,000 people. And for those of us who are taking care of these patients, we knew this was a real ugly, serious illness. We've had at Memorial at that time, over 1,000 serious hospitalizations. The county had 165 deaths. There's people I'm still dealing with who've had strokes and heart attacks and permanent lung damage, and they've lost smell. I mean, we think this is a real serious problem. And that was a pretty similar number at the time to the number of people who received the vaccine. And as we've said, in the vaccine, there were no deaths with the vaccine and very few serious adverse events. So to all of us who are working at the hospital, I don't know anyone who's taking care of COVID patients who wasn't clamoring to get vaccinated. So this didn't copy as well as I'd like. I stole this from a recent presentation by Monica Gandhi, who's an infectious disease specialist at UCSF. And, what she's doing is trying to compare these vaccines. There's a lot of questions. Which one should I get? Is one better, et cetera? Unfortunately, it's not quite apples to apples. So as I've mentioned, in the Pfizer and Moderna trials, what they did was they had, even those weren't exact, they had different endpoints. So with the Moderna vaccine, it's a dose day 1, a dose day 28, and then they started saying you don't have immunity for 2 weeks after. So they started looking at people who got infections, symptomatic infections 2 weeks after their second dose. So it's not exactly the same time frame. And, but it was pretty much the same. Variants were circulating throughout the world. And as I think everybody knows, they were very, very, very similar. As I mentioned, it's actually the Moderna trial. I was thinking it was the Pfizer trial. The Moderna trial, there may have been one patient hospitalized. Clearly, nobody died that has been vaccinated. The subsequent trials, again, get a lot more confusing because they have different endpoints. The Johnson & Johnson vaccine, for instance, is 1 dose, and they said 28 days later, and they were giving it at a time where there's circulating variants that the Moderna and Pfizer vaccine may not have looked as good at as well because of those, the binding. The vaccine was made to develop antibodies to the original spike proteins, and the modified spike proteins, it just may not have bound as well. We don't know. The critical point, though, is that light yellow column there that says protection from severe, well, both the light and the dark yellow column, protection from severe disease and hospitalization. And if you look at all of the trials that have been reported so far, we're talking about 70,000 people-ish that have been vaccinated. Other than one patient that's being discussed, no one died, and there were virtually no serious infections in all of those trials in all of those countries. So even in places like South Africa, which had probably the most worrisome variant that got the J&J vaccine, they said, well, it was 62% protective. Well, that was symptomatic disease, but even there, it was 100% protective for serious infections and hospitalization. So I think all of us feel, what do we really want in a vaccine? You don't want people to get really sick and you don't want them to die. And as far as we can tell right now, all of the vaccines will provide that. And for what it's worth, the strains circulating in the United States, we think they're all going to have pretty similar efficacy as the Moderna and Pfizer vaccines. So those are all kind of, when you're trying to compare vaccines, I got a lot of questions about that. It's getting harder and harder because there's different strains circulating, and there's a lot of unknown questions about long-term efficacy and boosters and all kinds of things. But I just wanted to put it in some context. And I think the most important point is that these vaccines, again, will keep you alive and keep you out of the hospital. So I'm going to run through a couple, or a number actually, of some of the questions that were forwarded to me and questions I've been asked, trying to answer them kind of quickly. And then I've got, I think, one other slide after that talking about the vaccine allocation and what's going on locally. But I'll try to answer some of these, again, most commonly asked questions about the vaccines. And then, we can extend the question period after that. So I've already tried to answer the first question, is one better than another? Most of us don't believe that's the case. And what everybody I know is saying, if you can get vaccine, get in line and get it. And there's virtually nowhere, at least in Monterey County, where you can kind of pick and choose. You might be able to if you really got lucky. We get these allocations intermittently, and I'll get 975 Pfizer and I'll open it to a Pfizer day. And when that day we're just doing Pfizer. And if you said, I don't want Pfizer, I want to come on a Moderna day, you might be able to do that. But yeah, you're lucky to get either one is, I guess, my answer. And I don't believe there's any difference. There probably is a little more discomfort we've seen with the Moderna vaccines. Actually, the amount of the liposomal or mRNA is actually like 3 times the amount in the Moderna vaccine, which may be why people have a little stronger reaction, but it may also mean they end up with better immunity. We just don't know that. This question, can I mix the vaccines right now? This question of 2 doses, can you get Moderna first and Pfizer second, or Pfizer first, Moderna second? We're really trying to discourage people from doing that. There aren't studies to saying how well that works. It probably works fine. You're already going to be kind of messed up on the timeframes and how they've been studied, since the second dose has a different dosing interval. The CDC has basically said if you you can only get the alternative one for your second dose, go ahead and do it, but it's not ideal and it's not anything we'd recommend. We're actually getting a lot of calls now. There are a lot of people in Monterey County that went out of the area to get their first dose. And then unfortunately, a lot of places in California are not getting their second dose, and people are asking us to give the second dose. So it's a bit of a mess right now, but we're all kind of working on that. Next question is the vaccine safe in pregnancy and breastfeeding? And, it's a complicated question. Normally, the FDA would never agree to, so the vaccine wasn't studied in children under 16. So the FDA did not give an authorization for use under 16. Those trials are going on right now. A lot of the teachers are asking, when are the kids going to get vaccinated? The FDA has said, no way. Kids don't tend to do pretty well. They tend not to die. They don't get very serious infection. We're not going to give this vaccine until we have some safety data. So those trials they're working on those right now, and we're told in a month or two, we'll probably have that answer. In pregnant women, it's a lot more complicated. And interestingly, the American College of Obstetrics and Gynecology and the Society for Maternal and Fetal Medicine have very strongly advocated that pregnant women should have the ability to be vaccinated. So while the CDC and the FDA is not advising it, they're saying it's kind of your choice. And I think most of us feel this is not a live virus. It is not going to cross across the placenta. It's not going to make the baby ill. And we're getting more and more data that pregnant women who get COVID, although generally they do well, we've probably had 100 pregnant women I've been involved with. We only had one who got pretty sick, and she ended up doing okay. But there is an increased risk of severe illness, and there's probably an increased risk of bad pregnancy outcomes, including fetal demise. And because of that, there's a pretty strong recommendation that pregnant women be offered it. And, I've talked to my friends who are obstetricians, and they feel pretty strongly that they should get it. But I think it's an individual decision, and I'll just kind of leave it at that. Interestingly, the next tier, I'm going to go over the tiers who's included in the ability to get vaccinated. And the next big tier, not quite the next one, is people 16 to 64 with underlying medical problems. And ACOG very strongly lobbied to include pregnant women in that group, and they have been included. So pregnant women will be offered the vaccine. They're offered it now. But again, it's an individual decision. I've had a number of doctors and a number of nurses or healthcare workers who've asked me about it. And, they probably have a greater exposure to potentially getting the virus. So in their case, I didn't think there was a question. They should go ahead and get vaccinated. But again, it's an individual decision. Tony Fauci was just quoted as saying that they're accumulating the data right now in women, not just the clinical trials that are going on right now, but since a lot of women have taken the vaccine, and they have over 10,000 pregnant women who've received the vaccine, and they're seeing no signal for any problems at all. The next question is, does vaccine cause infertility? This, as far as I can tell, and you can Google it, this is just like urban legend. And again, the Society for Maternal Fetal Medicine has come out over and over and over and said there is absolutely no scientific evidence to suggest this. So that's all I can say. What are the contraindications for the vaccine? So a lot of people have asked, I've got allergies, immunosuppressed, I had Guillain-Barré, et cetera. And as I've mentioned, the real only absolute contraindications are a really severe reaction to the first dose of the vaccine, a severe reaction to the components of the vaccine, which is mainly this polyethylene glycol. And if you've had a real serious reaction to other vaccines, particularly anaphylaxis, it's still recommended you can get vaccinated. You have to make your decision. But when we vaccinate you, we watch you for 30 minutes. If you never had that, we watch you for 15 minutes, but still it's not an absolute contraindication for vaccination. Actually, immunosuppressed to me, or immunocompromised individuals, are an indication, not a contraindication. And prior Guillain-Barré, there's no reports about Guillain-Barré in any of the COVID trials. There was some early data about getting Bell's palsy or facial nerve paralysis. doesn't seem to be bearing out. And there's been this bizarre report about people who've had dermal fillers as part of plastic surgical procedures who had swelling afterwards, but it's still very rare and it's not life-threatening and it goes away. So that's not considered a contraindication. The next question is, if I had COVID, do I need a vaccine? And if so, when? So the recommendations are that even if you've had COVID, you should get vaccinated. And the wording there is a little complicated. So what we believe is that after you have immunity from national infection, you have antibodies, as we've talked about before. But interestingly, you're part of the things the virus does to you is it shuts down parts of your immune system. And I won't get too complicated, but things like you develop antibodies to interferon, and your immune system as part of the infection isn't quite as robust as it could be. And because of that, it's recommended that you go ahead and get the vaccine. Now, some people have said if you had an infection, you probably have pretty good immunity for at least 3 to 6 months. And maybe you should kind of step out of line and let people who have no immunity get vaccinated first. But, that's an individual decision. And basically, the recommendation has changed a little bit, but currently it's once you've recovered from your infection, usually after 10 to 14 days, you can go ahead and get vaccinated. There's a lot of debate if you've had the infection, that may kind of act as your first dose, and you may only need one more shot and not 2 boosters. And actually in Great Britain and France, for instance, they are only recommending 1 shot after an infection, not 2. In the United States, they're still recommending 2, but that may end up changing as we get more information. Should we be giving 1 dose as a country? That's a really complicated, long question. The J&J vaccine, I think people know, is a 1-dose vaccine. We saw that in that chart that I showed, that after 10 days, you get a lot of immunity. And again, I think, with the mRNA vaccines, it's been demonstrated over and over that a second dose will give you a much heightened immune response with respect to antibody production. And probably there's other parts of the immune system called T memory and B memory cells, and you probably get a better response. I think it's a little bit like the question before. Virtually everybody agrees that you should probably give a booster with the mRNA vaccines, but a lot of people think it would be much better to vaccinate 200 million people with 1 dose, and then over the next few months, as we get more vaccine, we can get people boosters rather than vaccinating half that number with 2 doses. And that's actually being debated pretty vigorously on a national level. The question about when can children be vaccinated, I think I've already said. The FDA is waiting for some data, and then it'll do children under 16. And this is another big question. The last question here is, can I get or spread COVID-19 after I've been vaccinated? So we saw that the vaccine isn't 100% protective. People got symptomatic infection after being vaccinated. It's not that common, but it happens. We also know that symptomatic infections, there are people that get asymptomatic infections, and there's no reason to believe that they couldn't potentially spread the virus. So, yes, you can. Again, I tell people that if you've been vaccinated, I can tell you pretty comfortably that if you die, you're going to be the first person in the world that died after really having vaccine and having, that time period where we think you have immunity. You'll be one of the first people that ever got really seriously ill. It would be unusual for you to get a symptomatic or asymptomatic infection, but it's not impossible. And that's just the honest answer. And everybody has to kind of factor that into discussions about, could they bring it home, et cetera. I've put in the bottom right of this slide, most of these questions are answered in one form or another on the CDC website under that heading there. So you can follow that link or, Google interim clinical considerations for use of the mRNA vaccines. And I'm sure if J&J gets approved this weekend, there'll be similar guidelines, but the vaccine in many ways looks pretty similar with respect to all of these questions that we've looked at. Really quickly, this is the last couple slides, which is the last question everybody's asked, when can I get vaccinated? And this is the kind of tiering system. So we're down through February 17th, which means people 65 and over in certain zip codes, which correspond to The lower quartiles of the healthy places index census tracts can be vaccinated, so as much of Salinas and South County and North County, and you can live in any geographic location if you're over 65 and you're one of these essential workers, which includes teachers. Starting March 3rd, everybody over 65, regardless of where they live, and everybody in these essential worker class, such as teachers, will be open for vaccine. Now, just to put it in context, I run, as you heard, the Salinas Valley Medical Clinic. We have 500,000 patient encounters a year. We have 150 providers. We started by just trying to carve a piece of the pie out, and we thought we could reach out to 75 and older right away using our electronic medical record. And we had 10,000 people in our system over 75. We're getting roughly 1,000 doses a week. So just hitting the over 75 group was going to take us 2.5 months. We're now in the next tier. I mean, I'm trying to point out that we don't even remotely have enough vaccine as these tiers are rapidly accelerating. It's almost like a logarithmic increase, I'm exaggerating a bit, in the people who are eligible, and there's barely an arithmetic increase in the number of vaccines we're getting. So, it's just frustrating for all of us, but I keep saying by the summer, it's our belief that there'll be enough vaccine for everybody. We just kind of have to get through and get to that point. I think I'm going to skip this as a kind of complicated discussion about how vaccine comes into the county, how we administer it, how we have to report it. It's really a very complicated process. And who's making these decisions? It's really, again, a complicated mess, whether it's the governor or CDPH, and what are the ability of the county and who's distributing and allocating it. It's just, I literally am spending 4 to 5 hours a day in meetings trying to figure out how to, what I have to say, these rules and tiers are changing on like an hourly basis. And we're just trying to get the vaccine out. I heard Tony Fauci talking about this the other day and saying in West Virginia, where they just threw all this out the door. I never thought West Virginia would be the cutting edge of healthcare. They just said, get in line, first people. And they've done the best job of any state in actually just getting vaccine into people's arms. I mean, it is so difficult. I can't even tell you. And this is just a summary slide. I'm not going to go over again. I'm happy to share the presentation. People can look at it, but it just talks about conditions. And it just kind of summarizes a lot. We talked about what are absolute contraindications, what are relative, who we watch, et cetera. But this is just kind of another summary of what we talked about. I think this is from the University of Alabama. So I think that's it. I think I'm done with the presentation, and I'm happy to answer questions.
Thank you so much, Dr. Radner.
Yeah, you're welcome.
We are going to go through some of the Q&A questions first. And the most popular question is, once you get the vaccine, will it be required to be taken yearly as the flu vaccine is? And how long does it take before you are immune from COVID-19?
So, the reason that we do with the flu or other vaccines have to do it annually or periodically, there's a couple of reasons, right? One is that your immune system slows down or gets tired or doesn't work as well. So you get a booster to remind your immune system. The other reason is that the virus changes. So influenza changes significantly every year. It's a virus that has more dramatic mutations, and you'll get a very different strain every year. So those antibodies don't bind to the target. We just don't have the answer to that with the SARS-CoV-2 virus. We've only had the vaccine really for a number of months, and we don't know if people will have adequate antibody response for years. We're going to have to see. And right now, we're just not clear how much the virus is going to mutate. So it's a question, I've heard the CEO of Moderna saying, yeah, it's going to have to be an annual vaccine. I heard Tony Fauci the other night say, I'm not convinced at all that we're going to have to do annual boosters. So it's really unknown. And, the question of immunity, again, depends on the kind of vaccine or whether it was a natural infection. So as I mentioned, people get antibodies at about 7 days. They get kind of maximal antibody response after an infection at about 14 days. with an infection. And with the vaccines, as I mentioned earlier, with like the Pfizer vaccine, actually people are getting that chart levels off at 7 to 10 days. You definitely have some immunity a week after your vaccination. We think that you've got kind of your maximum immunity from the mRNA vaccines 1 to 2 weeks after the second dose, but there's definitely protection after the first dose.
Thank you so much. What about people who are breastfeeding? Are they eligible to receive vaccine?
Yeah, absolutely. So again, the guidelines are real. It's a little bit vague, just like I mentioned with pregnancy. It's very similar to pregnancy. Virtually every ID doctor I know and every obstetrician I've talked to in the colleges for obstetrics and gynecology feel strongly that pregnant women should be vaccinated and breastfeeding women should be vaccinated. There's absolutely no reason to believe that it's going to be harmful in any way. And in fact, getting vaccinated, there's passive immunity. You could provide antibodies to your child, both in vitro and through breastfeeding. But there isn't long-term data in large trials. So it's one of these things where it's an individual decision. I can tell you if it was my family, I would absolutely, if they were able to get vaccinated, I would have them be vaccinated in a second.
Wonderful. Thank you. Some specific questions about the types of vaccines. Are you eligible to select the type of vaccine you receive? Can you show up to a clinic and request Moderna or Johnson & Johnson? And a specific question about Johnson & Johnson, does it vaccinate against any of the variants, or is it just for the traditional strain of COVID-19?
So as I thought I'd mentioned this, but let me say it again. The operationally in Monterey County, as far as I know, you can't show up and pick because, again, there's a lot of complexity in vaccine storage, administration. We don't want to mix, we don't want to waste vaccine. So virtually all the clinics are saying, okay, today's a Pfizer day, today's a Moderna day. If you show up on that day, you're going to get that vaccine. And unfortunately, sometimes we don't know till the day before what vaccine we're going to get. So we've changed them ahead of, literally a couple days before. So no, you can't show up. You can show up and say it's a Pfizer day. I know of 2 patients out of about 7,000 who showed up on, one person showed up on a Pfizer day and said, I'm coming back on a Moderna day. And another patient showed up on a Moderna day and said, I'm coming back at a Pfizer day. But operationally, practically, no, probably by the summer when there's lots of vaccine to be able to choose. But our argument or my suggestion to people is if you're lucky enough to get a vaccine, get a vaccine. The J&J one, again, comparing the vaccines for the variant strains is almost impossible right now. There's no reason to believe that. My belief is that all the strains that are circulating in the United States right now, the UK strain and the Northern California strain, the 1429 strain, B1429, I don't think there's going to be any difference in efficacy between Pfizer, Moderna, or J&J, but there just aren't exactly the same trials. They studied the J&J trial at a time when there were these variants, and it didn't, quote unquote, perform it quite as well. But the critical thing is, in every scenario we've seen so far, all of the vaccines available prevent serious disease and hospitalization.
Great. When you are preparing to receive vaccine, do you need to take a COVID test before receiving it? Are there any specific nutrition or diet guidelines to follow prior and after receiving vaccine? And the last part of that question is, when you say a serious reaction to the vaccine, what does that look like? And why would your body have a serious reaction?
Well, so the most serious reaction is that thing called anaphylaxis, and that's a complicated type 1 hypersensitivity reaction where your body just has a horrific allergic reaction. And again, you can get swelling and hives and airway problems and your blood vessels dilate. And as we've said, that's the most serious reaction. Others are like, I kind of mentioned things like people get a really sore arm, or they get a neuropathy where their arm They may get numbness or their arm doesn't work very well. Those are the real serious reactions. As we mentioned, they're incredibly rare. And in the Pfizer trial, there are people who had, really bad arms who got the placebo, maybe just because they got a shot. So those are the serious reactions. I'm trying to remember there was a three-part question. One was about nutrition before the vaccine. And there's nothing that I particularly recommend. I just come in and don't worry. I mean, I worked the vaccine clinic on Saturday giving vaccines, and it was amazing how many people came in just frightened to death, and they were shocked at how it was painless and how, it was such a relief for people. So I just don't stress out. Come and get your vaccine, and most of the clinics are really efficient to move on. And I apologize, I forgot the first of that three-part question. What was the first part of that?
Do you have to have a COVID test to receive the vaccine?
Yeah, no, you should not have a COVID test. So I'm assuming by COVID test, you're checking for, there's two general types of tests, right? To see if you have an infection, which would be classically a swab, a PCR study or an antigen study to see if you're infected. And the other would be an antibody to see if you already have antibodies. We would just slow the entire process and cost billions of dollars if and the antibody trial studies, I'm not going to go into antibodies in explicit detail, but they're semi-worthless, I'll say. They're often false positive. And even if you had a previous infection and you had antibodies, as we've said, and we knew you had an infection, it's still recommended that you get vaccinated. So I would, if you're sick, you should get tested and not be vaccinated. But if you're completely asymptomatic, you should not get a test, either an antibody or an antigen or a PCR test.
Okay, a specific question about an item that might be contained in the vaccine, which is laminin. Can you talk about laminin and if it is present in the vaccine?
So I think laminin, I think that's that whole infertility issue. And again, I don't want to talk about something I'm not an expert at. My understanding, again, is there's zero data about even if there is traces of laminin, whether that causes infertility. Again, I would ask people to look it up, and every OB/GYN, fertility society, everyone is saying this infertility issue is not real. I'll just kind of leave it at that. And again, I'm not trying to avoid it. I'm just not an absolute expert on that. So
thank you. Thank you for clarifying. What about medicines? Are there any medicines that people might be taking? And is it okay to take Tylenol or ibuprofen after the vaccine if you're having discomfort?
Yeah, again, I've seen some weird recommendations on that. As far as I'm concerned, it's perfectly fine to take. There's not any medications that I can think of or I see as a contraindication to getting vaccinated. They may ask you if you're on a blood thinner because with the shot, they don't want to cause bleeding with the shot, but you still get vaccinated. And there's no medications that are a contraindication. And I don't think we've given lots of people Benadryl, lots of people ibuprofen, lots of people Tylenol. And I don't think it's certainly not going to make you sick. There's a tiny bit of theoretical concern that you may not have quite as vigorous an immune response with things like Tylenol and ibuprofen. But I actually think that's just not an issue. I think it's perfectly fine.
Thank you so much. This will be our last question, and any questions we didn't get to, we will share in a Q&A document on our YouTube page. But when is your best estimate as to when the general public will be vaccinated, including children?
Yeah, I think I hit it. I mean, I think the summer. I can't be any more specific. I mean, I think there's a really good likelihood that Johnson & Johnson is going to get FDA approved. They're saying by June-ish, they'll have 100 million doses. I mean, unfortunately, we're hearing we may get a very small amount of J&J in the next week or two, but they don't have a huge supply. It takes a little longer. So, I think there's going to be, as I've mentioned, I think by the summer, we're going to be converting from everybody in line clamoring to get the vaccine to trying to talk the vaccine hesitant individuals into getting vaccinated. But I look forward to that. Right now, it's really frustrating where we have people who are just scared, and grandparents who haven't hugged their grandkids, and teachers who aren't in school, and we just want to get it to the people who want it, and that's our overwhelming goal. And I think I'm pretty optimistic by the summer we're going to have that. Little concerned that we still aren't out of the surge period. We still may have another couple of tough months here, but we're pretty optimistic that we'll have plenty of vaccine by the summer. I wish I could be more specific.
Dr. Radner, I
Yes.
know that our time has come to an end, but I just want to again offer my appreciation and many thanks to you for taking this time with us today. I also, those questions about the timeline, we understand that they change regularly, and we do want to let all of the educators who are tuning in today know that there are conversations about setting up vaccine clinics as soon as we possibly can for educators. But as Dr. Radner said, your first opportunity to be vaccinated is the opportunity that you should take. And your own primary care provider may be reaching out to you via an email to open that opportunity to schedule your vaccine appointment. So if that comes first, take that opportunity. And if you have not yet received an email from your primary care provider with a link to schedule a date to be vaccinated, do know that your educational leaders are all working with our local healthcare providers, trying to establish vaccine clinics as soon as it is possible. And again, that all goes back to the vaccine supply coming into our county. But we just know we're all committed to making that happen for you. Dr. Radner, you are amazing. Thank you for your support. And I know that you too have a tie to the education community. Am I correct that you have actually been a former board member or are currently a board member for one of our local schools?
No, I've been a consultant. I haven't been a board member, actually. I've been a board member of about 12 boards, but not a school board right now. Yeah.
Wow.
Yeah.
Well, then you're just even that much greater in my opinion, because you're taking your time to help support us, and we're so thankful. Okay.
Thank you. Thank you all.
With that said, we're going to wish everyone a wonderful weekend. It's going to be important that we continue to wear our masks, wash our hands, follow all of those health and safety protocols that we know will keep us safe. So with that, we are going to wrap it up. Have a wonderful rest of the day and a wonderful weekend. Thank you for joining us today.